Great, thanks, Dr. Owens. It was a wonderful talk, and I'd just like to thank all of you for coming and spending your Saturday here, and Lisa and the whole Children's Cardiomyopathy Foundation for helping put all this together. So I was just going to continue with this line of talk and talk about some differences between the pediatric and adult populations, and then talk a little bit about some genetic testing and what are sort of the pluses and minuses of it. And there's additional sessions on that later today. So one thing we teach our young trainees when they're studying to be pediatricians is that children are not small adults, right? So we don't just take what we do for adults and miniaturize that and think that's the best way to manage a child. There are many, many important differences that make children different. And likewise, adults are more than just big children, although sometimes that's more of a case than others. But there are important differences, how we change over time, how our bodies develop, our risks of developing a disease, our risk of disease progression are very different, and even what's actually causing the disease can be very, very different. Even though the hearts may look similar, we may have a dilated cardiomyopathy in a child, so we have a large heart that's poorly functioning, and on an echocardiogram, we may see a very similar finding in adults, but what is actually the underlying cause of those sometimes are the same, but other times may be very, very different, and those differences are important. So I'll go over these in a few slides to come, but just some overarching, very broad differences in things like dilated cardiomyopathy, again, which are these enlarged hearts that don't function well, do not contract normally, are hypertrophic cardiomyopathies, these hearts that are thickened. So these are different diseases, and for sure. And how they present in childhood oftentimes are very different than how they present in adults. Both of these diseases can oftentimes, when they do present, they can present in very young children who oftentimes have very advanced disease. So it's not necessarily the case where there's a slow, steady decline that is noticeable, that, a child's becoming more tired, they just can't do as much, that develops, slowly over weeks or months or years. It can sometimes be very protracted. In our youngest children, they may develop, severe symptoms within the first weeks or months of life. And they can have some very challenges in the way we approach those patients, given their size and their complexity of their disease. And then I'll go into the what we call the natural history. So what actually, if we didn't do anything to these diseases, what would happen? Would they get better on their own? Would they get worse on their own? Would somebody fare poorly shortly after? Well, the sort of natural history is very different in these diseases in terms of children or adults. For restrictive cardiomyopathy, that's a very uncommon disease, but can be a very severe disease to treat, especially in children. And it can oftentimes have rapidly progressive symptoms where the only effective therapy, if that is the case in the current stage, is really a heart transplantation. And then left ventricular non-compaction, which is an incredibly diverse disease, both in children and in adults. And we can see a wide variety of presentation and symptoms from being very mild and patients that are asymptomatic to being very, very severe and refractory to therapy. And many of these diseases in children can also occur not as isolated diseases of the heart, but also diseases that may affect the entire body, the entire way the body metabolizes energy, or that can affect many other organ systems in the body. And that certainly has implications for how we think about the disease and how we want to approach the treatment. So this is a dilated cardiomyopathy. Again, these are hearts where this is the left ventricle here, where it's very enlarged and not functioning well. You can see the swirling here. Maybe you can see that, but that's blood that's swirling in the heart. It shouldn't do that. It should be pumping through the heart very aggressively. And when we see this swirling, we become very worried that one, the functioning of the heart is very poor, and then also that clots can actually form in the heart. If the blood flow is really stagnant, that clots can form, and that can lead to a stroke or other serious problems. And when we see this disease in children and in adults, there are hundreds probably of different diseases that actually cause the heart to look like that. And that's important to us because these diseases may have very, very different therapies. So as Dr. Owens went over, that we have these sort of broad classes of medications that we know in general are helpful for most patients that have these problems, but they may not be helpful for, go back, for an individual problem. So we have somebody that has a dystrophin, mutation. So these are all different genes which have been implicated in causing dilated cardiomyopathy. Well, it turns out actually people that have dystrophin mutations seem to respond pretty well to ACE inhibitors and beta blockers, but that might not be the same for patients that have this, actin mutation. And what we would love to have is disease-specific therapy. So we could test and we know that, okay, you've got a lamin mutation. Well, I know that this medication for patients with lamin is going to make you feel better, and these other medications are not, so we can tailor the therapy. So part of the challenge that we have in children and in adults with these cardiomyopathies is that there are so many underlying diseases that cause it. And these are sort of like, single genes that cause it. But again, in children, even more so than adults, we oftentimes see these diseases in the setting of these diseases that affect the whole body system. And these can sometimes be very severe diseases that it's important for us to identify so we can treat them appropriately. But these infiltrative diseases or storage diseases, there are some inflammatory conditions, things like sarcoidosis that we see in adults, but we hardly ever see in children. In fact, I've never seen a case of sarcoid affecting the heart in children. We have muscular dystrophies, which certainly can affect adult and children, but oftentimes if severe forms of muscular dystrophy, will affect people earlier in life. And then certainly diseases can occur as a consequence of other diseases, most notably the treatment of cancers. So then, how do patients do when they have these? Well, it's very variable, but it's also very, very different between adults and children. Again, many times adults that have dilated cardiomyopathy and develop heart failure symptoms, it can be a slow, gradual process. It certainly may not be that case. But then afterwards, there is a sort of a usual progression of disease, or at least a well-described progression. And these are just the results of this a very important study on Entresto, which showed that it gave a survival benefit over this medicine called enalapril. So it's called a Kaplan-Meier curve, but basically if everybody survived, these lines would be flat. You'd have 100% survivors. So you would want this line to be closer to the baseline here. You can see the patients that were given Entresto, it's closer to here, so more patients lived over, this is like a 3.5-year period. But you can see, these lines are fairly flat. The slope of these lines are constant. Well, that's not the case in children that have cardiomyopathy. In fact, this is the curve for children that have cardiomyopathy, of dilated cardiomyopathy, and they're dilated. So instead of seeing this slope that's even, you've got this curved line here. So this is backwards or upside down from the other slide. So you'd want to see 100% survivors. So if we had a flat horizontal line up here, would be 100% survivors. But we can see in children, if they're diagnosed with cardiomyopathy, instead of like an even risk over time, over that 3-year period, you can see that risk is about the same. Well, that's not the case with children. The risk is all up front, by and large. So in the first 2 years after the diagnosis, it's very severe. In fact, half of these children passed away or underwent heart transplantation, which is, not good at all. But the good news is if they can survive past that time period, well, then actually very few children die or undergo a heart transplant. So that natural history in children is very, very different than the natural history of adults. So how we think about the disease management, how we approach these patients is very, very different. And in children, they can actually have a remarkable recovery. So unfortunately, it's not every child, and this can also happen in adults as well. But we can see up to 30% of children can have a normalization of their function over that 2-year time period. So this initial time period after the diagnosis of a dilated cardiomyopathy in children is such a critical time period because, unfortunately, many of these children won't do well and will either not survive or need a transplant. But with medical therapy and close follow-up, actually a good number of these children, we wish it were more, but can have a completely normalization of their function over time, which is just uncommon to see that degree of normalization in adults. So again, the diseases, while they may look the same on an echocardiogram or an MRI, are actually very different. So just moving on to other types of diseases, the hypertrophic cardiomyopathy, as Dr. Owens went over, a thickened heart muscle. prone to arrhythmias. We worry about folks have a risk of sudden death. We worry about this in young people. When you hear of an athlete that dies suddenly, oftentimes they have hypertrophic cardiomyopathy as their underlying disease. So many children and adults will have an abnormality in what we call the sarcomeric genes, part of the heart that's involved with contraction. And so that is definitely true in children and in adults. But in children, this hypertrophic cardiomyopathy can also occur in the setting of these other types of diseases, and in fact, many other diseases, metabolic disorders, mitochondrial problems, problems with energy metabolism, syndromes like Barth syndrome or Noonan syndrome frequently will have cardiomyopathies develop with that. So it can be dilated cardiomyopathy as well. In that there's a subset of these hypertrophic cardiomyopathy patients very, very challenging to treat. That is certainly the case for very young children that have hypertrophic cardiomyopathy, especially if they have symptoms of heart failure. We really have no good medical therapy at the current time for these patients, and they oftentimes will need a heart transplant. And then a restrictive cardiomyopathy, again, a very rare disease, both for children and in adults. We oftentimes still today do not find an underlying cause, although sarcomeric gene abnormalities and other proteins can be abnormal. And we can see these rapidly progressive symptoms of developing arrhythmias, pulmonary hypertension, ischemia, strokes. Many of these children, unfortunately, will need a heart transplant because of their disease. And then lastly, I'm going to talk about left ventricular non-compaction. We're going to talk a lot about arrhythmogenic cardiomyopathy, but this left ventricular non-compaction, which the hallmark are these trabeculations, this, I think, is the most variable disease that we care for in pediatric cardiomyopathy, because we can have children that are entirely asymptomatic. Their hearts, aside from these trabeculations, seem to be doing very well. Other children who can be very, very sick with this and have rapidly progressing heart failure, refractory arrhythmias, be very challenging to treat. And they can certainly be associated with systemic disorders, and the outcomes are very variable. And some children do very well, some adults do very well, others have a more guarded prognosis. Still a lot to learn about all of these diseases, which really leads to what we hope we are entering the era of personalized medicine. So again, for all of these diseases that we see, there may be hundreds of different causes for them. And right now we have very coarse therapies that we apply to all of these different causes. And I think we are getting very, very close now to actually having disease-specific therapy. There's much research that's going on in this area, drugs that are being developed and are being tested in small populations that really get down to what is the specific abnormality that's causing it, and how can we do that? And even the slides that I showed you before, we have these curves, and we can say, okay, if we look at 1,000 patients with this disease, this is how they will do. But that doesn't really tell us how a patient will do or how your child would do that's affected with this. So it's incredibly variable, which is why partnering with your physician and your care team and understanding what is the best therapy for you or your child moving forward, because just because many patients with this disease may fare poorly, that doesn't actually mean that you're going to fare poorly with this disease or your child's going to fare poorly with this disease. There's an incredible variability, and we really would like to be able to personalize our understanding and our treatment for all of these conditions better. So one of the ways that we can begin to do that is with genetic testing. And, many of these diseases have an underlying genetic cause. And so actually understanding what is causing the abnormality is very important to us. It can give us information about prognosis for some genes and can tell us what things patients may be at risk for. Are they at risk for arrhythmias? Are they at risk for developing a heart block or very slow heart rhythms? For some diseases, we do have directed therapy. Unfortunately, that's the minority, but for some, we absolutely do. And it can help us screen other family members so we can understand, well, who else in the family may be at risk for developing a similar condition. It's not perfect. I wish that it were. Certainly when we get these results, it may not be clear. So we know sometimes what's normal, and we know sometimes what's clearly not normal, but there's a lot of gray areas. And sometimes we get these results back, and we're actually not sure. is this causing a problem or not? And over time, we learn more and more about it. And sometimes what we think is the truth changes over time. And, we learn more about it. And we think we found some abnormality and we think that's causing the problem. And 10 years later, we think, well, maybe it's more complicated than that. So, we do evolve over time. And I wouldn't say that's unique to genetic testing. That's true in medicine and maybe everything in life. Hopefully, we do learn more over time about things. Some people are worried about, discrimination. Why lose health insurance? Or will my children not be able to get health insurance if they have, a positive for this? This should not happen. There is a genetic non-discriminatory act, but that is a concern. And today we may get the results, but not have the ability to change the treatment plan or not have the knowledge of a disease-specific therapy. But it's certainly our opinion that these are helpful for most of our patients most of the time. We do learn a lot about the disease by doing that, and by having more and more families tested, we have learned a lot. And there are now the development more and more of disease-specific therapy. So certainly have this knowledge we think is helpful today and will certainly be helpful in the future. So with that, I would just like to thank you all. We'll be answering questions at the end of the next sessions, and we'll be around all day to answer any questions. Thanks again. With that, I would like to introduce my colleague, Dr. Lin from Children's Hospital of Philadelphia, who is the director of our cardiomyopathy